Do have one card wishing to speak in support of the bills. Dr. William Morrone from CMH, the 35th District Court. If you could find your way up, it'd be great. And whenever you're ready, Doctor, it's all yours. Thank you for being here.
Thank you. It's an honor to be here today. This is really important. It's not just about laws. It's not about reimbursement. It's not about paperwork. This is a historic moment because if telemedicine is done right, it will rank up there with hypodermic needles, the introduction of the X-ray, stethoscopes, and antibiotics. This will increase the access to care that right now people struggle with because of distance. And one of the things that we may not think about, but there's still a large number of Michigan residents that are underemployed and struggling with probation and parole. They flounder around the poverty line. They don't have gas money. They may not have vehicles. They're struggling with insurance. They lost their driver's license. And these people need access. And we can talk about how Medicaid can get you a taxi, but that's not available everywhere. I practice in 7 counties. I have 9 clinics. I serve 5 jails, 2 drug courts, and I have 600 active patients. My patients struggle to get to me because I have to go out and get to the community mental health. I'm in 5 community mental health organizations, but I'm an independent entrepreneur contractor. I rent my spaces in the community mental health, but I work in the Medicaid population. And I appreciate everything that Henry Ford's had to say, but most of the care that's delivered is delivered at my level and boots on the ground. And what I see telehealth doing is it's going to secure better care for women in OBGYN because of the distance thing. And we're going to be able to mitigate the epidemic of hopelessness that comes with mental health and addiction because you treat COVID-19 by isolating people and you treat addiction by socializing them back into society and making citizens. So coronavirus gave us exactly the opposite of what we needed to treat the epidemic we had before the virus. And I also see the next time a biological agent comes around, if we do telemedicine right and we have it in place, we will allow our urban hospital settings to come up for air because we can treat at a primary care level. And educated as a primary care provider, I think we had a very weak response. We needed the governor and federal guidelines to tell us really what to do because primary care was missing. Primary care wasn't trained to do this. I want to be able to say that we will expand rural care because I currently have, there's 83 counties in Michigan, and I serve 47 in my billing footprint. And a very important question came up when we were talking before about starting new patients. In the last 89 days with telemedicine, I have started 104 new behavioral health and addiction patients. Part of the reason why I could do that is the federal deregulation of the cumbersome guidelines. Telemedicine's been there for 20 years. But it was the guidelines, and I can tell you that defibrillators, antibiotics, X-rays, stethoscopes, that made a difference in medicine. HIPAA slowed a lot of stuff down. HIPAA's been a barrier for 20 or 25 years. HIPAA has to be balanced, and it was a very good point that HIPAA can go one way, not always both ways. I was there when HIPAA came out 25 years ago. The ambulance in Ogemaw stopped to transfer a patient in Roscommon and wouldn't give the charts and said they couldn't because of HIPAA. So to think this out and say that, well, you know, we've had HIPAA for 20 years, it may not be exactly the right thing. Maybe a HIPAA light, maybe HIPAA exceptions, but we will see zero risk of infections with telemedicine on the next round of whatever biological agent when people are treated through telehealth. And the question also came up about, the costs and the savings. Well, there's a balanced access. We're going to increase access. That may cost, but what we're going to be able to do is say that a provider doesn't have to be in 4 different cities. That provider can be in one clinic or his library or his kitchen or his dining room and still reach all those people, and then I don't have to drive so much. But the people that I go to don't have care. The first issue is access. We've had the hardware. I use Zoom. I use a MacBook. I use an iPad. I use an iPhone. I won't be using long, expensive Polycom systems like major healthcare hospital settings. I'm kind of like the small, frequent, fast terrorist in telehealth. I come and go, and people, they send the dog outside because it's barking, or somebody else has to have their sister come over to watch the kids. That's real telehealth. We need to teach it in the medical schools and not have people learn it the back end. That's really important. I have had the opportunity, I've been blessed to teach in 3 different medical schools here. And the opportunity to teach telehealth on March 27th, 2 months ago, I taught the first telehealth webinar in America sponsored by SAMHSA and the American Academy of Addiction Psychiatry. We recognize the barriers, and the states are the laboratories of democracy for deregulation. You are in the catbird seat. This is historic. This is the same as injections and x-rays and stethoscopes. We're turning the corner in a business in healthcare. And this is the future. Thank you for your time today.
Thank you. Committee, any questions for Dr. Morrone? Doctor, thank you again for taking time out of your schedule to join us here today, and we look forward to potentially making history here. Thank you again.
Thank you for having me.